Hello, today we're talking about acute coronary syndromes, the coagulation cascade. We need to first understand the atheromatous plaque. This is from work by Dr. Vamani's lab, where they showed a thin cap atheroma is the reason why the plaque ruptures. The panel A shows a lot of lipids in the plaque, and panel B shows macrophages. So there is inflammation involved in this. Um, this led to the concept of a thin cap fibroatheroma with macrophage infiltration, the release of matrix metalloproteinases, this collagen degradation, and thrombus formation. The inflammation part of this includes matrix degrading proteinases that are tightly regulated by inflammatory mediators, and this was felt to contribute quite a bit to the plaque rupture. Cytokines are involved in the initial steps of the atherosclerotic cascade, including endothelial cell activation, LDL, transcytosis, monocyte adhesion, and transmigration. And they play a very important role in the atherosclerotic process. The plaque rupture has major and minor criteria on pathology. Major criteria include presence of active inflammatory cells, a thin cap, a large lipid core, superficial platelet aggregation, and presence of hemodynamically significant stenosis. A critique is these pathophysiological findings were on autopsy, and there may be several other mechanisms involved in the living patient. Shear stress has been shown to contribute quite a bit to the plaque formation. There are areas in the arteries that have low shear stress and high shear stress. This is demonstrated on this image of the LAD. Vascular remodeling occurs as a compensatory change in vessel size as a result of increasing plaque burden and changes in local wall shear stress. Experimental studies suggest that low wall shear stress produces a plaque with vulnerable phenotypes, whereas oscillatory wall shear stress results in development of a more stable phenotype. This might explain why, even though the same individual with high blood pressure, high lipids, cholesterol, etc., may have a lesion at a focal point in the LAD and nowhere else in the vessel. These are images from optical coherence tomography. Panel G shows plaque rupture, panel H shows erosion, panel I shows a calcified nodule. So the concept has shifted from simply a vulnerable plaque to the vulnerable patient. Now we move on to platelet activation. Once a thin fibrous cap ruptures or fissures, a highly thrombotic contents of the necrotic core are exposed. Tissue factor is the most potent. This exposure of the lipid-rich necrotic core activates the coagulation cascade. The coagulation cascade contains the cellular component and the protein component. The cellular component are the platelets, they are the primary responders. They adhere to exposed tissue factor, they activate and change shape and result potent aggregating agents ADP, thromboxane A2, and form the initial unstable platelet plug. Then the protein cascade is activated. This is secondary, leads to stabilization of the clot, and the cascade rapidly generates thrombin, which converts soluble fibrinogen to insoluble fibrin. The fibrin threads form a mesh that binds the platelet plug and creates a durable occlusive clot. Initiation of the clot happens by exposed tissue factor, which binds to factor 7A, forming a complex that activates small amounts of factor 10 and factor 9. Small amounts of thrombin activate platelets as cofactors, and they activate factor 5 and 8. Activated platelets provide phospholipids where large complexes are formed. Now, aspirin, mechanism of action of aspirin, it irreversibly inhibits the enzyme cyclooxygenase 1 in platelets and as a result prevents the synthesis of thromboxane A2, which is a potent promoter of platelet activation aggregation. Because platelet lacks a nucleus, they cannot synthesize new COX-1. Therefore, the effect lasts for the platelet's lifespan. Aspirin activity works from 7 to 10 days. There are several potential therapeutic targets in platelets. The PAR1 receptor antagonist Vorapaxar has been shown to be harmful and not helpful. Thromboxane prostaglandin receptor antagonist is not used. ADP P2Y12 receptor antagonists include ticlopidine, clopidogrel, prasugrel, triclagor, cangalor, and these are all in use. Thromboxane inhibitors include aspirin, and this is widely used. Subsequently, GP beta 3 GP2B3 inhibitors such as abciximab and eptifibatide were IV. They were in vogue before better oral ADP P2Y12 receptor antagonists came out. Therefore, right now, abciximab and eptifibatide are no longer used as they contribute bleeding risk and do not provide benefit. Moving on to the P2Y12 inhibitors, Plavix and Tricalagor. Plavix is a thienopyridine. Its mechanism of action is irreversible. Therefore, it works for 7 to 12 days. It's a prodrug, requires activation. The activating pathway is genetically mediated. Some people are Plavix resistant as they cannot metabolize Plavix. Onset of action is slower and duration is long. Tricalagor or Brilinta is a cyclopentatriazolpyrimidine. It's a reversible inhibitor of P2Y12 receptor. It's an active drug, does not require metabolism. It's faster and more consistent. And nowadays, we're also moving towards Brilinta monotherapy rather than DAPT. Now, the advent of faster, more potent P2Y12 inhibitors like Brilinta diminish the incremental benefit of eptifibatide. Therefore, those IV agents are no longer used. Moving on to anticoagulants, these block the protein cascade, and commonly used ones are unfractionated heparin and low molecular weight heparin or Lobinox. Unfractionated heparin is a large polysaccharide. It inhibits thrombin and factor 10A equally by bridging them to AT. It requires a long chain. Pharmacokinetics are variable, highly protein bound, has a short half life. Low molecular weight heparin, on the other hand, Lobinox, is a smaller protein. It primarily inhibits factor 10A and has a higher anti 10A to anti 2A ratio. Its action is predictable but has a longer half life, 4 to 6 hours. IV heparin requires frequent monitoring. It's fully reversible with protamine, and Lovenox does not require monitoring and is partially reversible. Lovenox offers a more predictable anticoagulant response. There's a lower incidence of heparin-induced thrombocytopenia and has shown superior clinical outcomes in NSTEMI studies compared to unfractionated heparin. Alternative antithrombotics for patients with heparin-induced thrombocytopenia include agrotoban and biliverdin. Agrotoban is a direct thrombin inhibitor. It is cleared in the liver. Therefore, it's safe in patients with renal failure. Biliverdin is a direct thrombin inhibitor binding to the active site and exosite of thrombin. It's primarily enzymatically cleared in the renal and has a short half-life. Here is a schematic of how these agents work. As you can see, unfractionated heparin is a large molecule. Lovenox is a smaller molecule. Um, Agratoban works at a different site. Biliverdin works at a different site. And dabigatran works at a different site on the thrombin molecule. Fibrinolytics, on the other hand, work by breaking down the clot. Streptokinase is derived from the Streptococci bacteria. It was introduced decades ago. It was initially used to break up exudative pleural effusions and then found a role in thrombolysis for acute MI once the thrombin theory of uh, acute coronary syndromes was widely accepted. Mechanism of action forms a complex with circulating plasminogen, then activates other circulating plasminogen molecules. Fibrin specificity is low. It activates both clot-bound and circulating plasminogen, leading to systemic degradation of fibrinogen or a lytic state. TNK TPA, on the other hand, is a recombinant form of human TPA manufactured using genetic engineering. It directly binds to fibrin in the clot. It has high fibrin specificity, preferentially activating plasminogen at the clot surface. Therefore, it targets only clot-bound plasminogen, leading to less systemic fibrinogen depletion, therefore safer. TNK is better because it's administered as single bolus. It has a higher fibrin specificity. It's convenient, whereas streptokinase requires a prolonged IV infusion. That's all for now. More to come later.